Dr. Oi, now
Uh,
it's 3 p.m. You can start
yeah,
now.
okay. Dr. Bu and Dr. Bong, is that okay? We start?
All right.
Okay. So, welcome everyone today to the third week of our weekly webinar by College of Physicians Malaysia. So, this is our third week of the Haematology series. So, we are pleased to welcome Dr. Bu as our chairperson today. He is a consultant hematologist from Hospital Sultan Aminah Johor Bahru. Dr. Bu graduated from UNIMAS and obtained his MRCP UK in 2013, and he has completed his specialist training in hematology in 2020. He also has been actively involved in our clinical care and medical education. So please welcome Dr. Bu as a chairperson today.
Thank you, Ui, for the kind introduction. So today is our third week for our hematology part for our webinar. So this week topic will be mainly on thrombocytopenia. So the main topic will be the clinical approach. How do we approach to thrombocytopenia? And we are glad that we can have the opportunity to invite Dr. Bong to give the talk. Dr. Bong is my colleague as well. He's actually graduated from Sabah, then subsequently attained his MRCP in 2017 and completed his training in 2023. Currently, he is a practicing clinical hematologist in Hospital Sultan Ismail and has been actively involved in clinical trial and participated in medical applications as well. So without further ado, let us just invite Dr. Bong for his topic on clinical approach to thrombocytopenia.
All right. Thanks for the introduction, Dr. Bu. When it comes to management and clinical experience of hematology, I think we still have a lot to learn from Bu. So when there are like some more difficult clinical questions, sometimes most of the time we can still refer to Bu and the team in HSAJB. Actually, it's a very fantastic team in HSAJB. Anyway, thanks. Let's not waste too much time. I hope very much a big thank you to College of Physicians Malaysia for inviting me to deliver a talk on clinical approach to thrombocytopenia. Today, let me share the screen for a while. Right. Can you see the slides now? Is it okay?
No, no slide.
No slide.
No slide. I think you have to share. Yes, I think that's good.
All right. The main outline of my talk today would be more on a definition of what thrombocytopenia is, and then give a brief outline of what the hematopoiesis and megakaryopoiesis, and how do we approach these patients that we come across in our clinic in the emergency department with thrombocytopenia, and what's dangerous conditions that we really need to pick up immediately, because some certain interventions that can be done that can really have a life-changing interventions, and then go through some other common causes of a thrombocytopenia as well. I'll be presenting in the form of a series of case presentations, and then we'll run through some of the important investigations that are related to these conditions. So thrombocytopenia is defined as having a platelet count of less than 150,000 per microliter. Mild when it's between 100,000 to 149,000, moderate 50 to 99,000, severe those with less than 50,000. But there are some controversies when it comes to whether this definition truly makes clinical sense or not, because some significant bleeding usually occurs when platelet counts are below 30,000. Hematopoiesis involves the production as well as the differentiation of your pluripotent hematopoietic stem cells into your common myeloid as well as your common lymphoid progenitors, that as can be seen over the graphic over here. And the platelets arise from megakaryocytes, which is along the myeloid lineage in the myeloid erythroid progenitor, and then further they will be subdivided and they'll produce platelets from your bone marrow. So as you can see here, the formation of platelets come from megakaryoblast. When they differentiate into megakaryoblast, they get bigger and bigger when it forms the largest cell in the bone marrow, which is your megakaryocytes, 35 to 60 micrometer. And in these cells, you can see the cells, they are multinuclear, they're rich in granules, and then they start breaking off, forming the little anucleated cell fragments, which are known as platelets. These platelets only have a life expectancy of between 7 to 10 days, even in our blood cells. So it's like whatever platelets that you have are being constantly destroyed and replenished. So megakaryocytes in the marrow, this is a slide that you can see. The picture on the left shows a megakaryocytes with platelets being produced and being broken off from the cell on the site, right? So the megakaryocytes, you can see there's like multinuclear, and it's a very huge compared to the surrounding cells. And the trephine sample on the right can shows a multiple megakaryocytes on the background of your nucleated your neutrophils, right? And this is a normal peripheral blood film. As you can see here, there's a very good number of RBCs, a few neutrophils around it. And you can see the little dots on the background. Those are the platelets that you see. And this is what is being reported when they say how many per high power field, how many platelets per high power field. Those are the things that the hematopathologists count on your peripheral blood film. So what is the main use of platelets? Actually, they play a major role in primary hemostasis. Whenever there's an injury in your that is incurred on you, there's going to be a breach in the vascular wall. So the breach in vascular wall, what happens is there will be a release of your inflammatory factors, and then there's vasoconstriction of your vessels, and then the activated platelets will come and swarm around the area and cause adhesion, activation, aggregation, and cause a platelet plaque formation. And to form a subsequent more stable fibrin clot, that's when your secondary hemostasis occurs. That's when all your coagulation factors come about to, the intrinsic and extrinsic factors come down to form a very good stable fibrin clot to prevent further bleeding. So to start off the whole process, the primary hemostasis has to be functional for the initial steps to occur. So let's go by the first case. Let's say it's a Madam ZA, 30-year-old lady, was found to have following blood counts and health screening. Upon further questioning, there was not much of bleeding tendencies, just a bit of gum bleeding while brushing teeth. No hepatosplenomegaly, there's no PTK, no lymphadenopathy. HB is pretty good, 13.4 for a lady, white cell of 8, platelet of 25. The RP, LFT, FLP, MBS is normal. This is like from the health screening that you get outside, right? So what do you do? What are the differential diagnoses, right? There are so many. Etiologies of thrombocytopenia. This list is not exhaustive. You can just briefly, roughly segregate them into 3 main categories. One is whether they have a decreased platelet production, where there's increased consumption or peripheral destruction, or there's a sequestration. So, for example, something that is more along the line that can cause platelet production issues, alcoholic use, bone marrow failure syndrome, hepatic disease, infection, myelodysplastic syndromes, nutritional deficiencies like your B12 folate deficiencies. But like for peripheral consumption, this is, the classical thing would be your immune thrombocytopenic purpura. We always talk about ITP, but other things like mechanical destruction, preeclampsia, thrombotic microangiopathy, DIC, these would fall into this particular category, but many of them actually have an overlapping cause as well. They can have a reduced production at the same time as having an increased peripheral destruction, for example, like paroxysmal nocturnal hemoglobinuria as well. Sequestration occur, for example, in patients with hypersplenism, usually, right? Another thing that we have to think about is pseudothrombocytopenia. This one is a false platelet counts because of spurious laboratory results. So how do we go about investigating patients with the thrombocytopenia is we have to answer a few questions actually. First question is, are the platelets really low, right? We were told, like based on the slide, this one, the platelet counts were 25. Do we take it at face value? Is it really true that it's low? We don't know for sure, hence comes the most important test. PBF, you should always do a full blood picture, or depending on the centers that you are in, peripheral blood film or full blood picture. So let's, this case, I'll just present all the classical cases. Like they may not come in so classically, but sometimes, sometimes they do. So this is a case where you can see all the platelets are being clumped together, and the diagnosis of pseudothrombocytopenia is achieved. Basically, you have a lot of platelets, but they're all clumped together when you put your blood samples in the EDTA tube. And when you send the EDTA tube to be analyzed by the machine, they will interpret this, you can see 4 big groups of these clumps, right? They might calculate 4 of these platelets as 4 big groups of these clumps as 4 platelets. So in the end, you get a spuriously low platelet counts in your automated machine counter. But if you have some special markers in your sample, sometimes they would mention the platelet counts have an increased volume, right? So be wary of that, and it's always mandatory to send a blood film to investigate the patients with thrombocytopenia. So not all thrombocytopenia are the same. To paraphrase George Orwell, and the character, the 3 pigs in the Animal Farm, for you who have read the book. So some thrombocytopenia are more equal than others. So you just need to detect some life-threatening urgent conditions and pick up some red flags and do something about it, because they really do save lives. So the next approach is, okay, so let's say we already established the platelets are really low. So is the patient ill? Having an ill patient with thrombocytopenia will make you think about something more sinister, something of a more sinister cause, right? A 35-year-old lady came to the emergency department, brought by a family, confused, a bit of confusion, E3, V4, M5, a tinge of jaundice. So the tinge of jaundice might signify the presence of a little bit of hemolysis that is going on. She's not bleeding. There are no hepatitis megaly. HP is low. White cell is slightly elevated. Platelet counts of 20. But CT brain, despite patient confused, come to ED, CT brain now, right? But got no ICP. So we send an urgent PBF. So in this blood film, what we can see here is you can see a clear anemia with a lot of polychromatic cells. The more bluish cells that you see in your screen now are usually, these are the reticulocytes, basically fresh red cells that are being produced. The spherocytes, this signify a bit of hemolysis going on. Then the more worrying thing that you see in this picture is schistocytes. These are the cell fragments, the red cell fragments that have gone through fibrin strands that are being broken apart, causing the cells that you see here. And you can see there are hardly any platelets seen in this film. So you have a low platelet, you have schistocyte stains, you have hemolysis going on. This is a MAHA picture, microangiopathic hemolytic anemia, and it should really ring alarm bells to any doctors who are seeing a patient that comes in this kind of condition with this kind of blood film. So young lady, confusion, the CNS symptoms. So you think this could be a patient with a possible TTP. So you run through a plasmic score of 6 means it's a high risk. You send off Adam TS13 level and inhibitor levels to hospital Ampang. The results may not be back so soon. You can chase Dr. Vina in the lab in hospital Ampang, but usually they don't come back so soon. But you do not wait for the results to confirm it before you start treatment. Once you have a high risk of high suspicion of a possibility of TTP, you start treatment immediately. Start plasma exchange. You start your immunosuppressants, and then to treat the cause. So this is an algorithm when you have a thrombocytopenia with macroangiopathic hemolytic anemia. Then you look for a few things: neurological symptoms, or you got renal impairment, or you got GI symptoms. Neurological symptoms are more of along the line of TTP. If you get very severe renal impairment, these are more along the line of atypical HUS. Gastrointestinal symptom, patient having had a history of bloody diarrhea will be more along of the line of Shiga toxin induced or the E. coli 0157 variant that is causing the kind of hemolytic anemia that you see. So if you have platelet counts of less than 30, very low, normal or near normal renal function, response to plasma exchange, and then your Adam TS activity, which subsequently after a few weeks come back as less than 10, then you say, okay, this patient has had a TTP. Treatment is just plasma exchange, immunosuppressive therapy. Sometimes we use rituximab, and they usually respond pretty well to a plasma exchange. But if you have someone who has a less severe thrombocytopenia, but the renal function is probably much worse, and then you do plasma exchange, they don't really perform so well, and then finally the LMTS come back and it shows a level of more than 10, then it's atypical HUS is the diagnosis, and the treatment is very difficult to obtain. I think that's beyond the scope of the current talk today. I will not talk about it. Is the patient ill? Again, the next case is case 3, a 66-year-old man, E. coli septicemia, intubated in ICU, worsening platelet counts coinciding with the increasing inotropic support. Seems like the patient is not doing so well. It has been deteriorating in the ICU, blood sink during suctioning in the ETT, oozing from CBL, prolonged PT, PBF set. So at this point in time, I think all of you will be thinking along the line of, okay, this is a septicemic shock. Patient is in the IC already, probably going to dying soon. Again, the blood film is exactly the same, right? They will show you the same thing. Patient has got anemia, polychromatic cell scenes, spherocytes, schistocytes, and true thrombocytopenia. Okay, the difference is that patient has a prolonged PT, a lot of tissue factor being produced in a very severe sepsis causing a DIVC. So what is the story that we can learn from this is clinical context matters. You can have the same PBF, same kind of findings in a PBF, but the clinical context will make your diagnosis different. So a lady that comes in with confusion CNS symptoms with the same picture, and some ill patients in the ICU who's in septicemic shock having the same PBF, they don't have the same diagnosis. So that has to be taken into context. So in DIVC, the treatment is you treat the underlying infection, and then you replace whatever blood products that are deficient and hope for the best. So case 4 is patient ill again, 20-year-old girl, came with fever, bruising, pallor. While being evaluated in the ED, suddenly got a very bad seizure and then poor GCS recovery. CT scan shows a huge intracranial hemorrhage. HB 8, white cell 3.4, platelet 20. Again, everyone comes with platelet 20. I just like this number, actually. Nothing much. PBF urgent send. This is what we see, right? Different kind of blood film this time. You can see faggot cells in. Faggots are actually a stack of sticks, not the meaning. You can see this abnormal promyelocytes with bilobe nuclei, granular cytoplasm, anemia, and thrombocytopenia. So when you see these kind of cells, a classical picture, this is a case of acute promyelocytic leukemia. It's a hematological malignancy. I think if you have been following the talk over the past few weeks, I'm sure Dr. Yiman would have mentioned about the APML in his talk of hematological emergencies. What do we do now in this clinical context when you have a thrombocytopenia, involvement of other cell lines? That's with the APML diagnosed, then you have to correct the coagulability immediately, do a blood product transfusion, push up the fibrinogen to 1.5, sorry. FFP, correct the INR to less than 1.5. Platelets above 30,000, but since already got ICB, you have to chase it up to 100,000 lah. Commence ATRA immediately, 45 milligram per meter squared in divided doses immediately, and refer, right? But having had such a bad ICB in an APML patients, usually the prognosis is actually guarded, right? We picked up these patients, we try to prevent this from happening, hence the importance of all the blood product support to prevent that from happening once you pick up patients with APML. So summary from case 2 to 4 is that urgent PBF is mandatory. Be alarmed, especially if you have a presence of your microangiopathic hemolytic anemia. Just pick up the phone and call for urgent PBF. You're not sleeping. You're seeing patients in the ED. Don't let your colleagues sleep as well. Get them out, and then they'll be very happy to read the slides for you if it truly is indicated. And in these cases, they truly are indicated because you're going to do something in the middle of the night, and this thing that you do in the middle of the night can really save the patients. So EU cases usually involve multiple cell lines, and immediate intervention do save lives. And most of the hematopathology colleagues that we have, they are really nice people, and they really cater to your request. Is the patient bleeding? The severity of bleed, and then when do we expect the patient to have bleeding manifestations? So in this paper back in quite a long time ago, so as you can see here, the chart on the left, the risk category by platelet counts, the bleeding episodes, be it mild or major bleeding, do really increase exponentially as your counts drop below 20. So 8%, 20%, 65%, 95%. And whereas for major bleeding, you can also see when the counts drop down to 10, below 10, then that's when, the chart starts going crazy and starts shooting up. So the importance is the level, the quantity of platelets and the timing that the patient is being in that particular range would trigger the urgency of your investigation. So the clinical context is if you have someone who has had thrombocytopenia based on the previous historical blood test of 100, 90, 80, slowly coming down, then you do want to investigate what's going on, but the urgency of that is not as acute and not as urgent as someone who just comes with you acutely with bleeding tendencies with a platelet of less than 20. So that's the point that I'll try to send across. So the fourth question that we are talking about here is do you see any other cell line involvement? Is it only a thrombocytopenia, or there's a anemia as well? Is there leukocytosis? Is there leukopenia? Because they'll point to different diagnoses. So let's say a case 5, isolated thrombocytopenia. Exactly the same presentation, exactly the same slide basically. I just copied the slide and put it here, just change the case number. So having the same presentation does not mean they have the same disease. So you send out a blood film. This is the blood film that comes back. So instead of a spuriously low platelet counts, in this case, you can see there's a true thrombocytopenia. And in this particular platelets that you see, what is the difference that you see? You can see that the platelets are larger. The platelets are as large, or if not even larger than your red blood cells. So this is your giant, or just your large platelets. These are the young forms of platelets that are being forced out of the marrow. So these are the classical findings that hematopathologists would report, and that would point towards ITP. So, but before coming to ITP, of course, is a diagnosis of exclusion, and it's a clinical diagnosis. You have to go through a number of things, a very thorough history, no medications, no supplement use, no recent viral infection, no alopecia, not the SLE kind of thing, no family history, patient is not pregnant. So we can see a clinical diagnosis of ITP is achieved. And what do we do? Platelet 25. That's the blood film that you see. Do we need to admit the patient for further investigation and for treatment? According to ASH 2019 guideline for immune thrombocytopenia, those with platelet counts of more than 20 presenting first and have only minor mucocutaneous bleeding, an outpatient management would be sufficient, right? Unless the certain socioeconomic circumstances that preclude them from having to doing this, let's say poor social support, patients staying alone, then maybe not so worthwhile to send the patient home like that. But if not, then an outpatient management would be sufficient. Start the patient on high-dose steroids and then see back in 1 or 2 weeks' time and look at the response. Next case, 88-year-old nursing home resident, edentulous, admitted to the ward for dehydration. There was a pancytopenia. HP4, white cell 2, platelet of 20. It's got elevated MCV and elevated MCH. So based on the blood film, you see patient has a severe anemia, and the neutrophils are very grossly abnormal. You can see the segments are much more. There's like 7, the one on the top, and then there are like another 7 segments for the ones in the bottom as well. And then there's thrombocytopenia. So these are classical pictures that you can see from a B12 deficiency. Megaloblastic anemia, where a serum B12 falls below a limit of detection, the folate is very low. They start the patient on cyanocobalamin and then taper to a longer duration interval between the injections, and then you should expect improvement of counts within weeks. Case 7, let's say a patient transfusion-dependent beta thalassemia, 4-weekly transfusion. Past 3 to 4 months, the transfusion requirement has been increasing over the few months, from 4-weekly, now become 3-weekly. Also noted worsening of blood counts and also a rising ferritin. Pre-transfusion full blood count, not too bad, I would say. HP 7.6, white count 3, platelet 86. Again, not only just an isolated thrombocytopenia, but there's an anemia and there's a leukopenia as well. So your examination, you find that patient has a 3 centimeter liver, spleen size is 7 finger breadth, but check back records, like most of the thalassemia patients that we see, every time they come in, we don't really, many a time, we will sometimes, never get the patient to lie down and properly examine them. Then based on the records, it was actually done 3 years ago. It's been a long time since we last checked the patient's abdomen. So luckily, the blood film shows there's no blast, no dysplastic cell scenes. Albumin is 40, PTA, PTT normal. So that will point towards a case of hypersplenism, increasing splenomegaly and with the pancytopenia. So sequestration of blood cells in the spleen cause pancytopenia, and you can be caused by a few things: your portal hypertension, thalassemia, or you have a thrombosis in your splenic vein causing your portal hypertension. All these can cause your spleen to enlarge and subsequently cause hypersplenism and pancytopenia. What about things that will trigger a lot of physicians really? Let's say you have a patient with thrombocytopenia and the patient is pregnant. Let's say Madam ZZ, a 27-year-old Gravida 2 Para 1 at 34 weeks, referred by ONG team for thrombocytopenia. HP of 12, white cell 7, platelet 87. Patient is currently at 34 weeks already. Last appointment at the 30 weeks at time, a bit mild thrombocytopenia. They didn't want to disturb the medical team, could manage themselves. So of course, just left it at that. So now you can see a slowly reducing platelet counts in the patient. What should we do now? Should we give some steroids? Is the patient going to bleed during surgery? Is the patient going to bleed when the patient goes to term and deliver? Based on the blood film, you see normal chromic, normal cytic RBC, no schistocytes, normal white cell. The platelets are not too bad based on your accounts by our esteemed colleagues in the lab, 15 or 20 per high power field platelet seen. So what could be the cause of a thrombocytopenia in pregnancy? There are a few things to consider actually. The most benign ones would be your gestational thrombocytopenia. Based on what you see on the left side, based on a paper in 2022, if you have a platelet counts of less than 100 in the second trimester, or you have platelet counts of less than 80 in the third trimester, gestational thrombocytopenia would be probably more on the lower side, and the immune thrombocytopenia would be on the higher likelihood as a diagnosis. But you have to watch out for other obstetric cause, such as your preeclampsia, can help. So the other, based on the pie chart on the right as well, first trimester, you can see gestational thrombocytopenia hardly appears. If you have a patient with the low platelet counts in the first trimester, you really should consider that patient has an immune thrombocytopenic purpura or other causes instead of a gestational thrombocytopenia. But if you're in the second trimester, if your platelet counts more than 100, yes, maybe likely patient has gestational thrombocytopenia, but if there are less than 100, the diagnosis of gestational thrombocytopenia becomes less than 10%. But if you have a third trimester, your platelet count of more than 100, then yes, gestational thrombocytopenia looms large as a major proportion of the patient with the thrombocytopenia. But whereas if it's less than 50, there's hardly any gestational thrombocytopenia that can drop less than 50, and the causes such as preeclampsia and ITP would be your main consideration of your diagnosis. So thrombocytopenia, when the counts are pretty good, more than 80 in your third trimester, and has got no other risk factors, then you don't have to worry so much. But if they are a bit lower, then you just need to be aware of a few conditions that might cause it. So it is especially sinister and scary if there's presence of hemolysis and involvement of other cell lines, and also if there's evidence of placenta insufficiency like IUGR, oligohydramnios, blood pressure is borderline or sky high, proteinuria, then that will point more towards a patient with preeclampsia. So again, I'll just throw up this blood film over and over again. Again, the same blood film has a different diagnosis. Okay. If you see this kind of blood film in a pregnant patients, then you're in for a hard time. You're in for a difficult time. So first, I think let's go through the flow chart of how do we approach this particular group of patients. If thrombocytopenia, microangiopathic hemolytic anemia, you check the blood pressure, liver function, urine protein, PT-APT, and look for neurological symptoms, cardiac findings, kidney injury, features atypical of hypertensive disorder. If you have any of these features, then you will send an NMTS level. This one, maybe you can call AMPANG or ask them to expedite it if you have a patient that you are managing that is in this particular group. So if the NMTS is less than 10%, yes, you have a TTP. But of course, the chart here mentions if you have the results, only will start treating. This is not the luxury that we have, because if you have the high risk suspicion and then you already you have a patient like that on your hands, TTP would have already been started, right? But let's say patient does not have all these symptoms. Patient has the patient has got raised blood pressure, he has got raised proteinuria, then then you'll go to the left and more along the line of management of preeclampsia and help, and the obstetrics will really need to take the baby out as soon as possible for it to resolve. And in those particular group of patients, you don't really need to, apart from a blood pressure control and delivering the baby, there's nothing much you do that can really help the patient. And unless the patient platelet counts drop to a very low level, patient needs some surgery, then you're going to replace the platelet for the surgery, that is fine. Other than that, nothing much. What about the family history, medication, autoimmune diseases? I think this is another big family that we will have to approach. A long list of medications that can cause thrombocytopenia. This is not an exhaustive list. Basically, anything under the sun can cause thrombocytopenia. Somehow our body still has a weird way of interacting with certain drugs and then bundle up, become immune complexes and cause thrombocytopenia. So how do we approach them? Clinical condition, just look at the patient. If it's a drug-induced immune-mediated thrombocytopenia, they usually drop to a very low level, drops below 20,000. If it's not less than 20, then no, not likely to be a drug-induced immune-mediated thrombocytopenia. And is the patient bleeding? No, then it's not likely. Patient usually bleeds when at such a low level. The onset is very short. You have start the medication within a few days, patient platelet counts drop. Yes, that is more likely. And one of the drugs that you start, let's say, is on the list, um, the non-exhaustive list, then probably yes. But it's very likely then you stop the medication. Then then you give the IVIG and transfuse if the patient has severe bleeding. Another thing is entity that we see less nowadays would be heparin-induced thrombocytopenia. So let's say we get a referral for HIT patient has a thrombocytopenia. First, you go through a pre-test, the 40 score thrombocytopenia, timing, thrombosis, and other causes of thrombocytopenia. If you have a score of 3 or less, so you don't even bother needing to investigate further, and you can just say it's not likely to be due to heparin, and you can just continue with the heparin. But if there's a 4 to 5 or 6 to 8, then you have to investigate further, send a platelet factor 4 heparin immunoassay to Ampang. And I'm not sure whether we have the functional test or not. Probably need Boo to enlighten us a little bit. But then if you have really high risk of suspicion and you send a platelet factor 4 and it's positive, even before you have the test back, high HT 540 scores, then probably it's already more prudent to stop the heparin and switch to alternative anticoagulants. The ones that we really have in our hands usually are fondaparinux, your factor 10A inhibitors, which will play a role if the patient really still require anticoagulation. All right, what about another clinical scenarios that we face in our everyday clinical practice is what if the patient comes in, patient needs a surgery, or suddenly found that the platelet is low and you don't have too much time to investigate for the underlying cause. What is a safe level for a certain procedure? You can investigate at the same time, but patient comes in with intestinal obstruction for trauma. You don't get to wait and wait for a few weeks before a patient can go for surgery. Patient need to go in now. So how do you help the surgeons when it comes to providing a better and safer conditions for them to operate? So platelet levels for procedures and surgery in general ultimately still a surgeon anesthetist preference for obstetric purposes. Actually, the spontaneous vaginal delivery, a platelet count of more than 30,000 is sufficient. And for cesarean section, more than 50,000 by right is sufficient. But how many of the obstetrics surgeons would go ahead and do a surgery when the platelet counts are just, like say, 55? You can recommend as much as you want. You can say, based on British guideline, this is the recommended ones. But the ones making the decision whether to transfuse further would always still lie back on the surgeon. You can just give a recommendation, but they will decide what they want. Major surgery, platelet counts of more than 50,000 would be sufficient. If it's a CNS retinal surgery, then platelet counts of more than 100,000 is sufficient. So the next is, what about your cataract surgery? You have patients with immune thrombocytopenia purpura, platelet counts are always like 10, 15 like that, or borderline only, not so great. But patient getting blind already with the cataract surgery. They can go ahead with cataract surgery. They don't even need platelet transfusions because it's a bloodless, supposed to be a bloodless field and bloodless surgery. What about CVC insertion? More than 20,000 should be sufficient under ultrasound guidance. Lumbar puncture, more than 40,000 is sufficient. But if you need to put an epidural catheter, then a platelet count of 80,000 would be what's recommended. So this is just a brief graphic of, it's not exhaustive of all the procedures, but roughly, if you have a platelet count, if you are a patient in a ward, come in, sepsis for some infection, and got platelet counts, you try to keep it above 10. A prophylactic platelet transfusion, because you do not want the platelet to be at a very low level and the patient develop hemorrhagic complications. But like for the procedures, again, epidural 80,000, ophthalmic neurology 100. Major surgeries, usually more than 50,000 is sufficient already. And also take into account, even though our topic today is thrombocytopenia, but if you have a platelet count of more than 1,000, there would actually be a paradoxical increased risk of bleeding because of acquired convalescent disease. Just need to be very aware of that. So coming to an end, take-home message today is a good history helps. And PBF is mandatory in the diagnosis and management of all our patients with thrombocytopenia. You cannot just depend on the lab results and lab printout from automated counter and just treat the patient by that. You should always send a blood film and read the blood film. The blood film description, instead of just a conclusion, read the red cell description, read the white cell description, read the platelets. They tell you a lot of information because no one's going to conclude, oh, this is an ITP for you. Nobody can do that. But based on some of the findings in the blood film, you can actually, you know what the hematopathologist is trying to sell you. You're trying to sell a story. Okay, this is likely to be an ITP, but they won't tell you overtly in the conclusion. But you can tease it out from the results. But some other alarming features like schistocytes. You look for schistocytes in a blood film. You look for platelet clumps. You look for dysplastic cells. You look for blasts. So these are the things that you really have to find from your PBF. Not if you don't have PBF, really, I do not know how to approach thrombocytopenia. Really, this is one of the most important tests when it comes to investigation of cytopenia. So you really need to identify red flag features that may require urgent attention. Few things, again, schistocytes. Not few things, just one thing, schistocyte. That is, and also the blast and your abnormal promyelocytes. And then systemic approach helps in the diagnosis and management. And I hope I can shed a little bit of light on how to approach these patients. Thank you very much.
Okay, thank you, Dr. Bong, for the concise and informative presentation. So I think now we open for questions. There are quite a number of questions, I think, inside the chat box.
Wow.
Before we go to the chat box questions, maybe I can ask you one first. In the presence of patient with thrombocytopenia, when do you think transfusion may not be needed in the absence of bleeding? In what scenario do you think we do not need transfusion? Because every time you ask for transfusion, the blood bank will try to tell you why are you sure you need, because we have to go and find some platelet for you.
Oh, there are some certain conditions which a transfusion of platelets are totally contraindicated. For example, if you're a TTP, right? So if the more platelets you give, you're going to cause more of your intravascular, the more clot formation, and then you will worsen the patient's condition. So in those particular group of patients, platelet transfusions are totally contraindicated. So apart from that, the prophylactic transfusion of platelets, I would say usually we keep it at the level of 10, because with the counts of less than 10, even if you don't have bleeding manifestations, they would eventually manifest as bleeding if you don't transfuse this particular group of patients. I'm not sure.
In patient with ITP, do you routinely?
Oh yeah. Yeah. Even if you have patients with ITP, you don't routinely transfuse them, even if they have bleeding, right? Even if they have bleeding, if you have the mucocutaneous bleeding, you don't transfuse them because whatever platelets that you transfuse, you're going to get swarmed by your autoantibodies and you're going to cause further platelet destruction, and it's not going to help. The only time you need transfusions for your ITP is when they need to go for urgent surgery, or when a patient has major bleeding, for example, bleeding in your retroperitoneum, in your intracranial bleed. Then this particular group of patients, you really need to transfuse platelet while giving intravenous IV immunoglobulin and high dose steroids to try to boost your platelets as fast as you can.
That's good. Okay, so inside one of the slide, you mentioned about the timing where for ITP, when do you actually refer to hematologist? I read through the lines. It's mentioned that if it's more than 20, you can treat as outpatient and you refer to hematologist. In our situation, when do you think is the best time to refer you?
Immediately. Because what happens is the blood film, you're not going to get a blood film immediately. Just that's a very ideal picture. We're selling a very ideal picture of having a blood. You see a patient platelet there, and then you can get a blood film. Let's say in a primary care setting, you send off a blood film, it's going to take a while. And if you have already platelet count of 20 something in a primary care setting, and then you want to send a blood film, you're going to wait for it. It's usually takes 1 week, I would say. Probably the turnaround time for PBF from primary care settings will take a while. So usually by that time, we are happy to actually take referrals.
How about the district hospital with specialists?
Like that, if if they are dependable and they have a good patient ownership, probably they can they will still be able to consult us and then start treatment over there instead of seeing us. I feel.
Yeah, I totally agree on that. I
Yeah.
think
Especially
they should
first line.
be first line treatment should be able to be started, and they should be able to make a decision in terms of starting steroid if, let's say, the diagnosis of ITP is most likely. And the making a diagnosis of ITP is not difficult as long as you exclude some of the sinister causes of thrombocytopenia. I think that is an exclusive of exclusion, and by then you don't really need a bone marrow for confirmations of diagnosis. So you can actually start treatment when there is some refractory or the patient does not responded very well to the first line treatment, or there is any red flags, for example, hepatosplenomegaly, lymphadenopathy, or any other things that make you feel uncomfortable, or you think ITP may not be ITP is less likely, then I think it's time for you to call us. Okay, so as I mentioned, BMAT is not routinely done in ITP. When do you think the best time? Let's say a district physicians was managing an ITP patients. When do you think is the best time for them, where he or she need to consider a bone marrow assessment?
One is if you see the patient does not really respond well to your first line of treatment. That's one thing. Number two is if there's more than one cell line involvement. If it's not just a true thrombocytopenia, you can see something going wrong in your white cell or your HB patients got anemia as well, which cannot be explained by iron deficiency. Then probably it's time for you to do a bone marrow, and also the patient's patient profile. A young chap comes in with isolated thrombocytopenia and an elderly gentleman that comes to you with thrombocytopenia, they might have different etiology. So the more elderly you are, the less likely to be an immune thrombocytopenia, then the more likelihood that you have to really consider bone marrow. I mean, not all, but you should really keep that in mind.
That's good. Okay, so a few questions from the chat box. I think the first one is for vitamin B12 deficiency. When do you decide for parenteral treatment over enteral treatment with oral vitamin B12?
What do you think, Dr. Boo? I think for all our patients with B12 deficiency, we will give them parenteral treatment. While an edentulous elderly patient could develop that as a result of poor nutrition, many of the patients would actually have an the pernicious anemia that is causing that, which enteral B12 would not work. So for it to respond quickly and to make sure you are not missing out some other diagnosis, which is, let's say it's not B12 deficiency. You think it's a B12 deficiency. You really want to see a response. You give an enteral treatment, parenteral treatment immediately, and look for a response. If you don't get a nice response despite having insufficient B12, then you say something is not right. My diagnosis could be wrong. Then you may have to come back to your thinking whether there could be some other cause that is causing your pancytopenia instead of just a B12 deficiency. So I would say all of the patients will be on parenteral instead of like oral vitamin B12.
Yeah, a lot of times, the main reason why enteral vitamin B12 is not that effective because the absorption is only around 1%. So, and the absorption is by passive absorptions. So in the patients with gut and the intake of vitamin B12, the oral vitamin B12 that's needed for the absorptions to be adequate is actually very high dose. So parenteral treatment is still more preferable compared to enteral B12. Yeah, the second one is for platelet count in peripheral blood flow in high power field unit. How much is it approximately in full blood count terms? Any formula to use?
It used to be, I think it was taught to me is whatever per high power field, you times 5. That's the platelets that you see. So if
Yeah.
it are less than 5 per high power field, means less than 25 already. More than 30, then you have 150. So when you have when I say they're more than 30 per high power field, that's usually more than 150. That you have adequate platelets lah. So even you have a platelet count of like above 100, it will still be sufficient. So when they say more than 25 per high power field, they will just report still as platelet adequate 20 to 25 per high power field since. Because it is at that level, patient can do most things. You can go for brain surgery, you can go for ophthalmic surgery with platelet counts of more than 100. So that's the formula behind your per high power field platelets lah. That's how we quantify them.
Yeah, I totally agree. When to send FBC in citrated tube, do you prioritize FBP over citrated tube FBC? I think this is a very reasonable question.
I would say FBP is still, like I say, mandatory. If you see a low platelet count, you don't just, okay, never mind, I just send a citrated tube. First, you send a blood film. Send a blood film. And based on the blood film with the platelet clumps, they will be able to tell you whether you have sufficient or not. Sometimes you have clumps, but the clumps are not a lot. And then you will still consider is there like a reduced platelet counts in this particular group of patients or not? And then some hematopathologists would ask for a citrated tube for it to be quantified, but it really depends on the clinical picture. I would say, which one to do? I would say send the FPP instead of a citrated tube.
Yes, totally agree. So I think this is also quite a reasonable question. Do you give platelet transfusion for ITP patient going in for delivery? Any cutoff?
We try to, if a patient is an ITP coming for delivery and the platelet counts are low, below 30. So I think the cutoff for spontaneous vaginal delivery is 30,000. For a cesarean section is 50,000. If they are still below that at that point in time, and the patient still got time, you try to optimize it with IVIG with steroids. But if no time, his period is going in already, then there's no choice, then you just give the platelets during the delivery.
Okay. So
but you still treat them with the IVIG and then steroids at that time. You just to cover for the, who knows, maybe 2 days down the road. But a good platelet counts will still be better than having very low platelets post-delivery.
Yeah, I think the same questions. I think I will answer similarly. If the ITP patients need to go for angio or PCI at that point, then because you may need anticoagulant, then all this treatment is warranted. Not that common. We see a very severe thrombocytopenia at the same time having MI, unless it's other underlying causes.
And also the problem would be after, let's say it's MI, you stand the patient, then they say the platelet counts need to be at a certain level, patient has to be on double antiplatelets. That is a pain. It's really difficult. I would say it's quite difficult to treat this group of patients.
Yeah, so some patients we actually try very hard by giving some IVIG, metapred, push out the platelet before going in for the PCI or CAVG. But at any point, if let's say there's an emergency and need to be done urgently, I think we still transfuse platelet. But at any point, need to remember that the platelet have a very, very short half-life. So most of the time, we will suggest to transfuse pre-procedure or intra-procedure or post-procedure if needed. But the main treatment regime will still be the IVIG, metapred, because as what Bongs mentioned, it will be a long run that we are looking into starting anticoagulant and antiplatelet later. So for stroke patient, what is the platelet cutoff time, cutoff value? If you were to start antiplatelet, patient got ITP and have a stroke at the same time, what is the cutoff value?
I think my level of cutoff would be at the platelet count of probably 50,000.
Yes.
I'm not just basing off
Yes.
of a usual platelet levels that are safe for anti-platelets lah.
Yeah. I think that is reasonable. It depends on how many antiplatelet you want to start, because nowadays in acute stroke, we do start dual antiplatelet. So in patients with platelet count more than 50,000, I think single antiplatelet is quite safe. If you were to start dual antiplatelet, I think I would aim for a higher platelet count, at least of 80, 100,000. I think we got 4 minutes more. There's one question on, do you send ANA C3, C4 in pregnancy? And is it helpful to determine gestational thrombocytopenia versus ITP?
I don't think it is useful, because to diagnose ITP, you don't need ANA, C3, and C4 as well. So I will say to differentiate between which is which will be more along the line of how bad the thrombocytopenia is and at which particular trimester. Like the slide I mentioned before, if you have a very low platelet counts, then it's usually not a gestational ones. If your counts are more than 80,000 by third trimester, then it's very likely it still is. If you have any thrombocytopenia in the first trimester, it definitely it's not a gestational thrombocytopenia, and you don't need this test to tell you, and you can probably put the patient in the diagnosis of ITP. Whether you need treatment or not, that's a different matter altogether. That depends on the platelet counts.
Yeah, so I totally agree. You don't use this test to differentiate gestational thrombocytopenia and ITP. But if these patients were being diagnosed as ITP, then this test will be useful to differentiate secondary ITP and monitor for potentially concurrent connective tissue disease. Yeah, Bob, there's one question.
It's a clinical diagnosis.
Yes.
Yeah, it's a clinical diagnosis. Yeah.
Unfortunately, you don't have tests.
I think it's one of those things that's very difficult to. It's very difficult to prove. There isn't a single test that you can do to say, okay, I do a test. You send a blood film, you send a flow cytometry. Yeah, you got a acute leukemia. That's one of the nicest things about hematology. A lot of those things are very objective, and you know exactly what it is. But ITP is in that particular group where isolated thrombocytopenia, no other causes, and yes, you just think it's ITP, and then you just come to a diagnosis. And even if you don't really respond that well to your first line, you still have a very typical profile of a patient in that group. You may not even want to do a bone marrow in that particular group of patients, and you can just continue treatment with your second line. But different people have different opinions lah. It's quite a difficult topic, I would say, ITP.
Okay, so if there isn't any more questions, I think can we close the session?
Yeah, I think that's all. So it's already 4 o'clock. So I think thank you, Dr. Bong and Dr. Wu, for the insightful sharing session today. So thank you all for joining today's webinar. We'll see you next week for the week 4 of the Hematology COPM webinar. Thank you.
Bye-bye.
Thank you. Thanks for having me. Thanks for having us.
Thank you, everyone.